lectures this morning before we take a lunch break, and I'm going to do all of those. The first one is really a welcome, an introduction, and then we're going to focus on some key general concepts that you should know as we move into the specialty content of the week. Okay, do you sign in again? I think you just need to, you're already here on Zoom. You're good to go from this point. If they put in the chat that it's time to do the attendance question, you just do that, okay? All right, so I just want to start by introducing the GU faculty who you're going to hear from during this week. The way we've organized the abdominal week is that we have Monday and Wednesday being GU days, Tuesday and Thursday being GI days, and then Friday's a little bit of a mix. It's mostly GI with a little bit of GU mixed in. Okay, the faculty for the GU section include myself. I'm an abdominal radiology from Walter Reed National Military Medical Center in Bethesda, Maryland. I'm going to talk to you about the kidney, the bladder, and then we're going to do a case review at the end of today. You'll learn from Dr. Megan Lubner. She is from the University of Wisconsin at Madison. She serves both as the Associate Chief for GU Imaging, but also she is the new GI Section Chief. Okay, she took over for Dr. Maria Manning starting with this course. She took some of the more challenging topics for us. She's going to talk about the penis and the urethra, as well as the vagina and the pelvic floor. Okay, Dr. Gina Horowitz is from Northwestern University. She's in charge of their body imaging fellowship. She is going to talk about the cervix and the uterus. Erin Gomez is abdominal radiologist and program director at Johns Hopkins. She's going to talk about the ovary and the placenta and pregnancy-related things such as ectopic pregnancy or gestational trophoblastic disease. Dr. Baris Turkbay, he's a prostate MRI expert from the National Cancer Institute. He is going to be talking about prostate MRI. He's going to be providing that lecture virtually, so you'll be able to see that in Canvas. Okay, Dr. Deborah Rubens is from the University of Rochester, longtime AFIP and AIRP faculty member. She's going to talk about the scrotum, including testicular cancer. And then Miles Taffel from NYU, former program director at George Washington University. He's going to talk in both the GU and GI sections. And for GU, he's going to talk about the adrenal glands and the retroperitoneum. Okay, so you're going to meet all those people over the course of the week. I just thought I would throw out who they are ahead of time. I think sometimes it's helpful to kind of know what to expect and who you're going to learn from. Okay, so with that as an introduction, let's get to our first lecture, which is going to focus again on key concepts in radiologic pathologic correlation. Really, what I'm hoping to do with this lecture is to provide a big picture overview of some of the concepts that you should kind of be aware of before or as you start a course in radiologic pathologic correlation. It's some of the things that I have kind of adapted my thinking over time as I've had more experience with radiologic pathologic correlation. Okay, so with that, let's get started. Okay, so the first kind of subtopic in this lecture is going to be developing a differential diagnosis by understanding anatomy and histology. Okay, so kind of the first thing I want you to understand is that the fully formed GU organs are composed of just a few major tissue types. Okay, so these are epithelial tissue, mesenchymal tissues, neurogenic tissues, neuroendocrine tissues, and then the germ cells. Okay, so if you think way back to medical school when you're learning about embryology, these are the end products of development. These tissue types started out as our three germ cell layers that formed as early as week 3 with gastrulation. So for the GU organs, you can think about the important epithelial tissues as being derived from the mesodermal as well as the endodermal layers, the mesenchymal tissues arising from the mesodermal layer, and then our neurogenic and neuroendocrine tissues arising from the ectoderm. Okay, so let's kind of work through these one by one. Okay, so we're going to start off with our epithelial tissues. These are the kind of tissues that often line structures. Okay, they may form tubes, or they may form the lining of tubes, or they may organize themselves into glands. Okay, generally they're going to be involved in either secretion or absorption, as well as serve a barrier type function. Okay, so some examples of the epithelial cells or epithelial tissues within the GU system would include the cells that line the renal tubules. That's going to be our source of renal cell carcinoma. Okay, the cells that line the bladder, the urinary collecting system, and urethra. That's going to be our source of urothelial carcinoma. Okay, the lining of the uterine cavity and the cervical canal and the vagina and the fallopian tubes. The lining of the uterine cavity is what gives rise to endometrial cancer. Okay, and then finally, any tube in general. So if you think epididymis or vas deferens, that's going to be lined by an epithelial lining, as well as glandular organs like the prostate. The epithelial tissues is what forms the glands within the overall prostate gland. Okay, our second major tissue or cell type that we'll encounter in the GU system are mesenchymal tissues. You can think about these as the tissues that provide a framework to the organ. They can contribute to motility, and they can provide protection or provide blood to the different organs. Okay, so we're going to test out the chat here. Can you think of an example of a mesenchymal type tissue you may encounter, maybe within an organ, let's say the bladder, okay, or within a space, let's say the retroperitoneum, okay? What kind of things would lead to contraction or protection? Okay, good. So for the bladder, you can think of the bladder muscle. That's a very important mesenchymal type tissue, okay? Okay, the covering, okay, like a capsule, excellent. That's connective type tissue. And then the retroperitoneum, fat, good. That's a major component of the retroperitoneum. It provides the cushioning for the organs. Okay, so the examples I offer you is smooth muscle. You can think about that again in the bladder wall or maybe the uterine wall, the connective tissue and stroma. The stroma separates out the cells within an organ. The connective tissue can be dense connective tissue, maybe encapsulating an organ. The fat of the retroperitoneum, the blood vessels which lead to the organs and then eventually branch and run in the submucosa, as well as the lymphatics of the submucosa. Okay, what about the nerves? Okay, so for neurogenic type tissue, you can think about the peripheral nerves and their supporting Schwann cells. In for the GU organs, we tend to think of the nerves exiting out the neural foramens and running in the paravertebral location. We can also think about smaller branches of nerves actually innervating the organs. And in most organs, including the GU organs, they're going to run in a submucosal location. Okay. What about, there's also neuroendocrine type cells. These are endocrine cells that rapidly respond to impulses from the nervous system. Okay. Think about the GU organs. Okay. A little organ, sometimes it maybe has a V or a Y shape that can contain a large number of neuroendocrine cells. Anybody want to throw that one in the chat? The adrenal glands. Okay, when you think about the adrenal medulla being a major source of neuroendocrine cells. Okay, what about clusters of cells traveling in the posterior mediastinum and retroperitoneum, maybe organizing themselves at the aortic bifurcation? Okay, paraganglia. Okay, good, good, good. Okay, and then in addition to those places, you can, oh, I'm freezing 1 second. Okay, in addition to that, you can have just scattered neuroendocrine cells that mix in with the epithelial cell populations in many different locations. Probably the two important ones to be aware of is with the bladder and with the prostate, and therefore can give rise to neuroendocrine type tumors in those locations. Okay, and then finally, the germ cells, right? These are going to be our spermatozoa and our ova. They live in the testes and the ovaries, and occasionally you can encounter them in weird places, such as the retroperitoneum, related to the path of migration during development. Okay, so now that we kind of know the different tissue types or cellular types that we may encounter in the different organs, I just wanted to show you how they tend to be organized. Okay, so this first picture is just a representation of the renal pelvis, and this box is showing us the layer of the wall of the renal pelvis. So typically the epithelial cells will be aligning a cavity. So in this example, we have the urine space aligned by the urothelium. The urothelium is just a fancy type of epithelium. Okay. Below that, we'll have a basement membrane and then some loose connective tissue. We can call this the submucosa or the lamina propria, which is going to contain nerves and blood vessels. And then deep to that, we'll have mesenchymal tissues forming the smooth muscle of the wall of the renal pelvis. Overlying that, we may have additional connective tissue forming a serosa or an adventitia. Okay, this organization is going to be very common. We're going to see this in the bladder, in the collecting system, in the uterus, where we have an epithelial lining of the endometrium, followed by the thick muscular layer of the myometrium. We see this with any tube. If you think about the fallopian tube, it's a muscular tube with an inner epithelial lining. Okay. Another common kind of pattern is what we see here with the ovary. The ovary has what we call a surface epithelium. It's also closely associated with the epithelium of the fallopian tube. Within the ovary itself, there's a large amount of connective tissue forming stroma. The germ cells also live within the ovary, which are organized into follicles with surrounding sex cords. Those are actually specialized mesenchymal type cells. Okay, so why am I going through this? Why do I think it's useful to kind of think about things this way? Because if you encounter an unknown mass, if you can go back and think, okay, what's the anatomy I'm dealing with? What cell and tissue types live in that anatomic space? You can then create a broad differential as a starting point. Okay. So if that organ or space contains epithelial type tissues, you can think about hyperplasia, dysplasia, and carcinoma as being important things to consider. Okay, if you know that this organ or space contains mesenchymal tissue, think about which ones. Okay, say it's the bladder, it has a large amount of smooth muscle. You should think about leiomyoma or leiomyosarcoma. Okay, if it's the retroperitoneum and you know there's a large amount of fat, you can think about a lipoma or a liposarcoma. Okay, if you know it's a space where nerves run through, you can think about our neurogenic tumors, including schwannoma, neurofibroma, and malignant peripheral nerve sheath tumors. If you know it's a place that contains neuroendocrine type cells, you may want to put paraganglioma or our spectrum of neuroendocrine tumors on your differential. And then finally, if it's a place where germ cells live, you got to think about the range of germ cell tumors. Now, it's important to realize like which ones you should consider vary by organ. Okay, both the occurrence of these things. We don't think about germ cell tumors in the kidney, for example. And then the frequency also depends on the specific site or organ. Usually the epithelial tumors will be our dominant tumor type, kind of the first one listed, the one you should think about first. But smooth muscle tumors become important in certain places, such as the bladder and the uterus. Okay, so that's kind of part one or section one, developing a broad differential diagnosis by remembering your anatomy and histology. Okay, if you have any questions about that, I'm happy to answer them. Otherwise, we're going to go to section two, which is called Pathology 101. Okay, I hear the boos coming through. Fortunately, you're muted, so that kind of silences some of the boos. But you're here at a radiologic pathologic course. So I think it's important to cover a little bit of pathology just so you can kind of understand some of the terms that you're going to hear throughout the course. It will also prepare you as you go out into your career and you're involved in tumor boards and these terms come up over and over. It's kind of nice to know what they're talking about rather than just kind of sitting in the audience. Okay, so the way we're going to approach this to keep it kind of brief and to the point is that we're gonna pretend that we found a mass at imaging. It had a broad differential diagnosis. The patient went on to either have an excisional biopsy or a percutaneous biopsy, and we're just going to think from the viewpoint of a pathologist how they would kind of start dividing it up into potential major tumor types. Okay, so the first major tumor type would be an epithelial derived tumor. Okay, we know epithelial tissues live in our GU organs. Okay, so how would a pathologist like try to decide that they're dealing with an epithelial tumor? Okay, so the first thing they would do is they would look at the architectural growth pattern and cellular behaviors and see if they resemble kind of normal lining structures or normal glandular tissues in their organization. Okay, so what does this mean? Well, they may look for cells to be organized in nests or clusters. They may see, do they organize themselves into glands? That would be an adenocarcinoma. Okay, do they see areas of keratinization? That would be a sign of a squamous cell carcinoma. Then they'll look for cytological features that like indicate that they arose from an epithelial cell, so they have an epithelial past. Okay, these are things like, do the cells show polarity? Okay, is there a clear apical side and a basilar side? Okay, are the cells showing cohesion like epithelial cells that make up a barrier would? Do they have any cytoplasmic inclusions, like things that are responsible for making? An example of that might be mucin within the cell. Okay, that would push them towards an epithelial type tumor. And then they would do some special staining with immunohistochemical staining and this can be very specific to the organ, but in general, epithelial type cells will be positive for cytokeratins. They'd be positive for EMA or epithelial membrane antigen, and they'll be positive for cohesion markers like ECAD here. Okay, so that's like what a typical epithelial type tumor would look like to a pathologist. Okay. The next main type is going to be a mesenchymal tumor. Okay. And this differs significantly from epithelial tumors. So what does a pathologist kind of look for when they're thinking about a mesenchymal tumor? Well, the cells are going to be organized into bundles or fascicles. Okay, sometimes they'll have a more unique pattern, such as a storiform pattern, which means it's the cells are kind of radiating out from a central point, or it might have a herringbone pattern where the cells are kind of arranged in these progressive V-shaped structures. Okay. The cells themselves, instead of being oval like a typical epithelial cell, will be more spindle shaped or elongated. And then sometimes they contain characteristic nuclei. A good example of this would be cigar-shaped nuclei with blunt ends. That's what we think of with a smooth muscle tumor. Okay. In addition to the cells, they'll notice that there's an extracellular matrix. This is usually a very important feature. Uh, Mesenchymal tumors can produce a variety of things. They can produce collagen, myxoid, or a chondroid or osseous matrix. And this has a nice correlation for us because tumors that secrete a lot of collagen should be T2 dark and tend to show delayed enhancement because they're very fibrotic. Tumors that make a lot of myxoid matrix should have a lot of water content. Okay, so they should be very T2 bright. And then you know from your experience reading X-rays and seeing bone lesions in X-rays, you can definitely detect a chondroid or osseous matrix by seeing areas of increased density within a lesion. Okay, they will also do immunohistochemical staining here, but the pattern will be different. Instead of being positive for the cytokeratins, it may be positive for vimentin. And then the different mesenchymal tumor types have different markers associated with them. But SMA, which is smooth muscle actin, and desmin are associated with smooth muscle tumors. CD31 and ERG tend to be associated with more vascular type mesenchymal tumors. Okay, so that's like the main two that they're going to encounter all the time, and they're going to try to distinguish, are we dealing with the epithelial tumor of that organ, or are we in the mesenchymal group? Okay. Beyond that, I'm just going to highlight two more kind of briefly. Okay. The first one is our neurogenic tumor, because we certainly encounter these in the GU section. We think about these as being either schwannomas or neurofibromas usually. Schwannomas have a unique architecture where they're kind of a mixture of densely packed Antoni A cells and loosely packed Antoni B cells. Neurofibromas are more haphazard in their organization. The cytologic features will match or more resemble a mesenchymal tumor. They tend to be made of these elongated spindle cells with some collagen matrix, but they also kind of blend in with nerve fibers, and their nuclei will be thin, elongated, and wavy, which may help suggest that it's a neurogenic tumor rather than a smooth muscle type mesenchymal tumor. And then they can confirm that origin by using IHC staining with S100 or SOX10 being positive in neurogenic tumors, but not in smooth muscle tumors. Okay, the last type will be our neuroendocrine tumors. These have unique features as well. The architectural pattern will appear either organoid or trabecular, or sometimes organized in rosettes or pseudo-rosettes. A related pattern, which is super common in paragangliomas or pheochromocytomas, is something called Zellballen, where the architecture is groups of cells arranged into balls. The cytologic features, they more resemble epithelial cells, where they're more round or polygonal. The cytoplasm tends to be amphiphilic, and then the chromatin takes on this salt and pepper appearance. And then finally, they have a pretty unique IHC signature, where they'll be positive for neuroendocrine markers, including chromogranin A and synaptophysin. Okay. Beyond just putting it into a broad histological group, using immunohistochemical staining and molecular characterization um, will often allow the pathologist to be very specific in their subtyping of a tumor. Very specific markers exist for many tumors. For example, beyond what I already talked to you about, if they're concerned a tumor is a clear cell renal cell carcinoma, for example, they will do a special panel which focuses on proving that diagnosis. For clear cell, it happens to be PAX8, CA9, CD10, and CK7. But just know that beyond just putting it in a major group, there are panels specific to individual tumor types. And then increasingly, more commonly in modern medicine, we're always looking to find therapeutic targets. For example, if it's a gynecologic malignancy, there's a medication that can be used to target the folate receptor alpha. So they would test for that using AHC staining. Okay. Uh, in addition to just doing histologic classification, it's also very common to do specific genetic analysis. Okay, this can come in the form of either hotspot testing, looking for specific mutations, like such as a BRAF mutation, or can come in a more comprehensive form using next generation sequencing. Uh, when it's the more comprehensive profiling, the pathologist will be trying to identify things such as, is there microsatellite instability, and are there defects in the mismatch repair genes? They would commonly associate that with Lynch-based tumors. Are there problems with homologous recombination process? Is the tumor deficient in that process? That's very common, especially with like ovarian type cancer. And then what is the overall tumor mutational burden? That usually is helpful for predicting response to immunotherapy. Okay, so the pathology part is very complicated, and you're going to learn some of this along the course of the next month. I just kind of want to introduce you to some of the major ideas and hopefully have you have heard them before you get into the specific lectures. Okay. The next pathology concepts I want you to be aware of is grading and staging. Um, uh, let's just review what these terms mean because they are very important terms. Okay, so in the chat, what does grading mean? I can't have put everyone to sleep already. Okay, differentiation, excellent. Okay, so that is the right answer. Okay, how aggressive it looks compared to natural, unlike natural tissue. Perfect, that's the perfect answer. So grading is how much cells look like normal cells. What's their degree of differentiation? A pathologist will look for different things in different tumors, but in general, the idea is for an epithelial tumor would be, do we see glands and tubules? That would be lower grade, or do we just see cells marching through the tissue? That would be higher grade. Okay, how pleomorphic are the nuclei? The more pleomorphic, the higher grade the tumor is. Okay, what's the mitotic count? How active are the cells in dividing? The higher the number of mitoses, the more abnormal mitotic figures, the higher the grade. Okay, and this is very important because grade impacts prognosis. Okay, the specific grading system will vary by tumor, but in general, it tends to be a 3 or 4 grade grading system When it's a four-grade grading system, it usually looks like what I have written here. It goes from well differentiated to moderately differentiated to poorly differentiated, and then completely undifferentiated or anaplastic. Sometimes they condense that into three grades, but when it's a four-grade system, that's what it looks like. Okay. In the chat, okay, can we think about some of the more common grading systems used in geopathology, things that you should know about that you will hear about all the time? Okay, so what about for prostate cancer? Good. The Gleason grading system, you'll hear that all the time. Okay. What about endometrial cancer or almost any gynecologic cancer? What's the major group of people that create the grading systems? FIGO, excellent, good. So FIGO is the typical grading system for most gynecologic malignancies. And then finally, renal cell carcinoma. This one's probably a little tricky, maybe not heard of quite as much. Does anybody know what the grading system is for renal cell? Okay, Bosniak is for mass characterization. That's different than grading. Um, Who, excellent, fantastic, good. It used to be the Furman system. Most people now have moved on from the Furman system and now use what they call the ISUP, International Society of Urologic Pathologists, World Health Organization or WHO grading system. Okay, so you'll hear a little bit about that. Okay. Oh, I gave it away. Staging. Okay, so what is staging? Okay, staging is not what cells look like. Staging is the anatomic extent of disease. Okay, this is a major determinant of the treatment plan. Okay, if you look at the NCCN guidelines, this would be like what you do with different stages of disease. And then two major concepts I want you to be aware of with staging is what is in situ disease versus invasive disease. And that tends to be whether the basement membrane is violated or not. If so, it becomes invasive disease. Okay. And then the second thing is once something is invasive, the basement membrane has been violated, usually stage is going to be determined by either the depth of invasion, and you'll see that that is very common for our common GU malignancies, uh, or a combination of depth of invasion and size. Okay. So let's look at an example. This is just an illustration showing bladder cancer. Okay, bladder cancer is an epithelial-based tumor, okay, arising from this urothelial lining or epithelial lining. Stage is going to depend on depth of invasion. Okay, the further down we get beyond the epithelium into the submucosa or the muscle or even beyond the muscle, the higher the T stage. Okay. Here's an example of that in action. Okay, so here's a patient who doesn't have bladder cancer. Instead, they have endometrial cancer, again, arising from an endometrial epithelial lining. You'll see there's all this large amount of tumor bulk, but it's not about the size of this tumor bulk. It's about how deeply invades. Okay, so in this case, it's invading into the myometrial layer. Okay, and that will determine the overall stage. It doesn't matter how much this tumor bulk is, it's how deeply it invades. Okay. The other pattern for staging to be aware of is for things such as renal cell carcinoma or sarcomas or adrenocortical carcinoma, where it's about size first and then invasion. Okay, so for a typical renal cell, many tumors are confined to the kidney. Okay, so there's not much in the way of depth of invasion yet. So tumor size will determine what the T1 and T2 stage is. Once it breaks through the capsule, then it becomes about depth of invasion and what structures are involved. Okay, so it's either going to be only depth of invasion or size followed by depth of invasion. Okay, excellent. So we have made it through the first two sections, and we're going to move on to one more section of the introductory talk. And now in this talk, in this part, we're going to focus on narrowing your differential, or kind of how you can think about a case. Okay, so first things first is to identify the location. Okay, is it in a space? If it's in a space, can you put it in a specific organ within that space? Okay, once you put it in an organ, can you put it in a specific location in that organ? For example, your differential diagnosis for a mass arising from the Endometrium, which is in the uterus, is very different from a tumor arising from the myometrium, which is also in the uterus. Okay, so we want to be as specific as we can about anatomy. Once we do that, we're going to think about the underlying histology to create our broad differential. And then we're going to apply patient-specific factors. Okay, we're going to see how old is the patient, what is their sex, do they have any known risk factors, have they had any prior surgeries or carry any medical diagnoses, do they have any known pre-exposing genetic conditions. Okay, that will hopefully help to narrow our differential to a more limited number of things. And then finally, we're going to really get to use our imaging, specifically radiologic pathologic correlates that we commonly encounter. Okay, so uh, for Rad-Path correlates, what are the major correlates we should look for? Okay, what do these correlates look like on our major modalities? And then which tumors commonly demonstrate these correlates? That's what we're going to spend the end of our time doing. Now, I'm not sure if you understand what I mean by which correlates we should look for, so I'm going to give you a hint for the first one. Okay, so the first one I think of when I think about Rad-Path correlates is fat. And by fat, I mean macroscopic fat or bulk fat or true adipose tissue in general. Okay, so now your challenge in the chat is to try to come up with your list. Okay, so what are some things beyond fat that you can look for that are a pathologic feature, like a type of tissue that has a definite imaging finding? Okay, calcium, wonderful. Okay, calcium at under the microscope, calcium that we can detect at imaging, especially like CT or ultrasound. Okay, blood, excellent. Blood and hemosiderosis. Blood goes through blood products, goes through a spectrum. Okay, we got fat, melanin, excellent. That's a good one. Stroma, fluid, vascularity, excellent. Vascularity is an excellent one. That's all about our enhancement patterns. Mucin, good. Fibrous tissue, excellent. Scar is a focal area of fibrous tissue. Those go hand in hand. Necrosis, excellent. Okay, this is getting to be a pretty good list already. Does anybody think of any other ones? Myxoid, good. Okay, is it a capsule? Okay, what's the growth pattern? How is it encapsulated? Is it not encapsulated? Excellent. So our challenge is going to be to like learn all of these and then associate them with different diagnoses so that we see them in action and that helps us refine our diagnosis. Like what makes sense given what we see. Okay, great. Okay, so if next slide, I'm giving away. You probably found ones that I didn't even think of, but this is kind of the list that I thought of. I'm sure there are many more. Okay, so I think about, is there macroscopic fat? Is there lipid? We often refer to lipid as microscopic fat. Calcification you got, fibrous tissue you got, mucin or myxoid material, both are very watery. Got that, hemorrhage, okay, the range of blood products from acute blood all the way to chronic hemosiderin, edema, necrosis, how cellular a tumor is. Okay, often like our diffusion weighted imaging can tell us about cellularity. Vascularity, we got cyst formation, what the growth pattern is. The capsule kind of got at that one. Okay, so there's endless numbers of these. I'm sure if I went through all the lectures people are going to present over the course of the month, there'll be more added to this, but this is kind of my starting point. So the next thing we're going to do is we're going to take a look at some of these in action. Um, so the first one we're going to do is fat. Okay, so what does fat tend to look like in imaging? Fat tends to be hyperechoic at ultrasound, tends to be fat attenuation at CT. That's usually in the negative range, like less than -10. Okay, it tends to be T1 hyperintense until we apply fat suppression, and then it becomes hypointense. And then we may see chemical shift artifact. We usually think of that more with lipid, but little bits of fat can show it, or at the margin of large areas of fat, we may see chemical shift. Okay, here's an example of a big adrenal myelolipoma where you can see CT showing a lot of fat, yellow material gross pathology, and all these white cells. Those are adipocytes under the microscope. Okay, plenty of other things show macroscopic fat. Okay, along the top here, we see an example of a uterine mass. This is a lipoleiomyoma. In macroscopic fat at CT, T1 hyperintense loses signal with fat suppression at MRI. Along the bottom, we see our first image is a classic angiomyolipoma made of macroscopic fat. Our second and third images are in and out of phase images showing multiple T1 hyperintense masses with peripheral chemical shift. These are multiple angiomyolipomas in TS. Excellent. And then our last picture is a mature cystic teratoma with a fat fluid level due to sebaceous material and then a coarse calcification. Okay, can anybody think in the chat of another common mass in the GU system or GU or GI that contains bulk fat or macroscopic fat? Maybe a clue would be a big mass. Oh, dermoid, that's the same as the last picture I'm showing you. That's a mature cystic teratoma. Dermoid mean the same, but that's a great one. RCC occasionally can have bulk fat. We usually think of lipid, AML. Yep, that's a picture there. Liposarcoma, excellent. Okay, hold clear cell for you because we're going to talk about the differences there in our next lecture. Okay, good. Okay, what about lipid? What is different about lipid? What do I mean by lipid instead of fat? Oh, myelolipoma. Dr. Lubner in the crowd. That's a definite A for that one. Good. Okay, lipid. What is lipid? Okay, so lipid is usually intracellular microscopic fat. Okay, tends to cause low attenuation at CT. It often causes cells to look very white or clear at pathology. In addition to low attenuation at CT, we often see loss of signal on opposed phase images. Okay, so that is more indicative of lipid rather than bulk fat, which loses signal with fat suppression. Okay, here are kind of our two most classic GU diagnoses. Okay, so here is a low density mass at CT, which shows clear loss of signal from in phase to out of phase. That's a adrenal adenoma, lipid-rich adrenal adenoma. Okay, here is a classic clear cell renal cell carcinoma, solid expansile hypervascular mass, relatively hyperintense on in phase, some areas of signal loss on out of phase. Okay, that is our signal drop. That is indicative of intracellular fat or microscopic fat, which we refer to as lipid. Can anybody think of a GI diagnosis? We see it every single day, which leads to signal drop on out of phase imaging or very low density on non-contrast CT. Fatty liver. Okay, yeah. So here's just an example of fatty liver. Okay, excellent. Okay, our next example is going to be fibrous tissue. Okay, fibrous tissue tends to be hypoechoic at ultrasound. Oh, is it freezing? Mine's moving. Is it freezing for everybody? Good here. Okay, I'm sorry. Hopefully it'll catch up for you. Maybe it's your connection. Okay, so we're going to do fibrous tissue. Um, so fibrous tissue tends to be hypoechoic at ultrasound, tends to be T2 hypointense, and it tends to show weak enhancement and a more delayed enhancement pattern. Okay, so here is an example here where we have a large mass with a central scar made of fibrous tissue. Here is a mass that has more fibrous tissue throughout. This is an ovarian fibrothecoma. This, I think, was a chromophobe renal cell carcinoma with a central scar. Under the microscope, we'll see this pinkish type tissue. This is collagen deposition forming that fibrous tissue. Okay, here are some examples of imaging. So here again is that fibrothecoma, very dark on T2 in large portions of the mass, weak enhancement. It would be delayed and progressive if I gave you more sequences. Okay, here is a Brenner tumor with a cystic component and a big fibrous component. Okay, very T2 dark. Here is a big renal mass, probably a chromophobe, could be an oncocytoma with this low density central scar. And then this last one here is this is the uterus. Here is a uterine fibroid. This is actually a smooth muscle tumor, but it has a lot of collagen deposition in the matrix, so it's dark. And then here is a cyst adenofibroma, where you have a cystic space and you have a thick fibrous wall. Okay. Can anybody think of another GU example? Let's go retroperitoneum. Let's say there's some upstream hydro. What kind of thing, what kind of fibrous thing happens in the retroperitoneum? Great, retroperitoneal fibrosis, wonderful. Okay, that was too easy. You guys are too smart. Okay, and then what about GI? What if we have a liver mass, shows progressive enhancement? Maybe it's maybe it's scarring down and pulling in on the capsule. Oh, F and H has a fiber scar. That's good too. That's not what I meant, but cholangio. Yep, excellent. Okay, but those are both good thoughts. Okay, good. Okay, we could do this forever and ever. We're going to do a couple more examples. Okay, how about myxoid and mucinous? Okay, those are different things, but the commonality is they're very high in water content. Okay, so things that are high in water content, you should think about being hypoechoic at ultrasound, low attenuation at CT, high T2 signal intensity at MR, and then show kind of weak enhancement. Okay, here's an example here where we have mucin containing pocket. This is a urachal carcinoma. Okay, so this would be very dark on ultrasound, low density on CT, and very bright on T2 weighted imaging. And then that corresponds to all these mucinous areas, mucin-filled pockets in this mass. Okay, here are some examples along the top and here. Oh, sorry, I don't know if you can see my mouse. Along the top and here, these are large mucinous tumors. Okay, these are mucinous epithelial tumors of the ovary. Notice they are very low in density, hypoechoic at ultrasound, high in T2 signal intensity. And this last one is a mucinous tumor of the bladder. Okay, so you can see centrally it's very low attenuation. Okay. Our next Rad-Path correlate is going to be blood products. Okay. And remember, blood products will change in appearance depending on the stage of the hemorrhage. Okay. So this one's a little more challenging. You can think about blood as being high attenuation on CT, showing high T1 signal intensity, even on fat suppressed images, showing low T2 signal intensity, especially with chronic type hemorrhage. Remember, blood shouldn't enhance. So subtraction images may be helpful. And then as blood products mature and hemosiderin deposition becomes more of a part of the process, you may see loss of signal on in-phase images due to that presence of that hemosiderin. Okay, here are a range of different pathologies showing blood products at different stages. Okay, in this first one, we still have some hyperattenuation due to this diffusely hemorrhagic renal cell carcinoma. Here we have a cystic mass that contained this locule full of blood. This is actually, I think, a pheochromocytoma that underwent hemorrhagic degeneration, forming this high T1 signal intensity area. Here's a T2 weighted image with a very dark mass. This is a papillary renal cell carcinoma that contained a lot of blood products, including hemosiderin. Here's an endometrioma, really high T1 signal on this fat suppressed image. And then this is an area of adrenal hemorrhage. We call this a pseudocyst, showing mildly hyperintense signal with not much internal enhancement, maybe just a little bit around the periphery still. Okay. I think we're running out of time here, so we're going to do just one more example. Yeah, our last example is going to be necrosis. Okay. Here is what does necrosis look like? Well, necrosis is often irregular in shape and will show non-enhancement at CT and MRI. It's often low attenuation, often low on T1 and high on T2. The caveat to that is sometimes there's hemorrhage within that necrosis, and if so, that's going to alter both our density and our T1 signal intensity. Okay, necrosis can have an overlap with scar and with cystic degeneration. So these signs aren't all perfect. We kind of have to use them in the greater context of what we're seeing and what the patient's history is. Okay, so here's an example of tumors that all showed significant necrosis at pathology. Here's a big adrenal cortical carcinoma with central non-PET activity, which is centrally necrotic at CT. Here's a huge renal cell, very vascular in the periphery, but has undergone significant central necrosis. Another example of the same thing, peripheral hyperenhancement, central necrosis. And then this is a large pelvic sarcoma, similar idea, large solid tissue mass, central necrosis, some of which is hemorrhagic. Okay. Um, all right. So I think we're going to stop there so I can make sure I can give you a 5 minute break before you go on, before we start our next session. I guess in summary, I just wanted to highlight for you in this introductory talk that it's important for you to know anatomy and go beyond anatomy and understand the histology of the organ and space you're dealing with. Doing this will allow you to create a broad differential based on the tissue types that exist. Okay, pathologists can have excellent tools to make the specific diagnosis. I tried to show you a few of those. And then finally, use location, your patient information, and any Rad-Path correlates that you learn to detect over the course of this month to really provide the most narrow differential or the specific diagnosis whenever possible. Okay, so hopefully this was helpful for you as an introduction. I'm going to give you about a 5-minute break, and then we're going to meet back up and we're going to do renal masses. Okay, so thank you for your attention.